All right, well, it's 8 o'clock. I want to welcome everybody to our medical grand rounds on Lucky Friday the 13th. And before we start, I just wanted to put a pitch in for a reminder for two initiatives that we are trying to roll out for the Department of Medicine. One is our Thanksgiving kudos board. So please post something that you are thankful for, or somebody you want to thank, whatever you would like. Everyone are invited to participate. And the second is we are trying to get your pictures and photos of family, of you, of pets, of kids, whatever, for a Department of Medicine photo montage for the holidays. So that just send your photos to Clint, and I'm looking forward to seeing all of the creative ideas and poses that you submit. So thank you for helping in these endeavors. And now I'm going to first introduce Dr. Christy Bartles, who is well known amongst all of us, a rheumatologist extraordinaire, physician scientist, who will introduce our special guest speaker. So Christy.
Fantastic. Well, it is my extreme pleasure to introduce Dr. Ann Rosenthal for Grand Rounds this morning. Dr. Rosenthal received her MD graduating AOA from Johns Hopkins University. She completed her residency in internal medicine at University of Rochester, and she received her rheumatology training at Medical College of Wisconsin. She's a globally recognized research leader whose principal interests involve the pathogenesis of calcium pyrophosphate deposition disease, also known as pseudogout, although Anne would evangelize if there's nothing pseudo about it. Her work has been funded by the VA and the NIH since 1991. Her other research interests include osteoarthritis and gout, and she recently co-authored the 2020 American College of Rheumatology Gout Guidelines. She also does some research on musculoskeletal complications of diabetes. She has over 90 original publications, 19 chapters, over 30 invited reviews, and she's presented at many national and international conferences and meetings. She's been a past member of VA study sections and a number of NIH study sections, and she's currently a standing member of the Skeletal Biology Development and Disease Panel for the NIH. She's an active mentor also for the U.S. Bone and Joint Decade Investigators, which is actually how I met her a number of years ago. And she has a strong interest in faculty development. She's the Will and Cava Ross Professor of Medicine in the Division of Rheumatology and the Chief of Rheumatology at Medical College of Wisconsin currently. She's an ELAM alumnus who has led the MCW Women's Faculty Council in the past. She's been a vice chair for faculty development, and she currently has leadership roles as the Associate Chief of Staff for Research and Development at the Zablocki VA, as well as an Associate Dean for Research at the Medical College of Wisconsin. She maintains an active clinical practice, and she's been a fellow of the American College of Physicians, a winner of a number of several teaching awards, and a recognized clinician expert as Best Doctors of America. And having just launched her outstanding symposium at the American College of Rheumatology last weekend, I know that we are in for a terrific presentation. So with that, I'd like to introduce Dr. Ann Rosenthal, Will and Cava Ross Professor of Medicine, to present her talk on Pseudogout Comes of Age. Thank you, Ann.
Thank you so much, Christy, and I am thrilled to be here, and thank you for the kind introduction. I am super excited to be invited to Madison for a couple of reasons. First of all, I feel like I'm part of the rheumatology division there. Christy and Karen Hansen and others have been fabulous collaborators and friends. I also have an important family member in the Department of Medicine who I will not name, but is a major critic of mine, and I am hoping that he is here and listening today. I really do love to talk about pseudogout and CPPD to pretty much anyone who will listen. So here is the CME slide, and we will start because we have a lot to talk about today. I have no financial disclosures relevant to this talk because there are no FDA-approved drugs for CPPD, and we're going to talk about why. and why not in the next few minutes. So another disclosure of mine is that a couple of years ago, I was asked to speak at the ACR, and my talk was entitled CPPD, the Forgotten Crystal. I've also had titles assigned to me, such as CPPD, Unmet Needs, CPPD, the Ignored Form of Arthritis. And I think at some point it was really discouraging to talk about this disease. And I feel like it's a wonderful time in CPPD research right now. I am super excited about the accomplishments we've made, not only in beginning to understand the pathogenesis, but beginning to identify some druggable targets, and very excited about the work that is going on at an international level to define this disease so that we may begin some clinical trials. So I have been accused, as Christy knows, of being slightly evangelistic about CPPD, and I am. What we're going to do today is talk about the history of CPPD, because I think it's really interesting, the clinical spectrum, so that you can recognize this disease when it occurs, and a little bit about how CPPD is currently treated. I'd like you to be able to talk or learn about some of the diagnostic modalities for this disease and some recent really exciting progress in this area, because obviously making the diagnosis is critical to managing these patients. And lastly, I'm going to talk about some of my work looking at pathogenic mechanisms, largely focused on crystal formation and the ramifications for developing novel and effective treatments. And I think along the way, I'm going to try to convince you that this is a very important disease. And I have underlined, hidden in my talk, 6 reasons why I think this is important. First of all, let's all agree on what I'm talking about. So calcium pyrophosphate deposition disease, also known as pseudogout, or at least one form of it is known as pseudogout, is arthritis caused by these crystals. So these are calcium pyrophosphate crystals found in synovial fluid that deposit in cartilage, and the radiographic correlate of that is chondrocalcinosis, which we'll talk about. And it causes both an acute and chronic arthritis, largely in older people. It's the 4th most common form of arthritis in adults, and yet remains really underrecognized and understudied. The nomenclature of CPPD is a major hurdle, and you will hear me calling this disease pseudogout, CPPD, CPDD. All of them are terrible, and we really need to work on the nomenclature of this disease. But when you think about it, I like to think about Prince, who was the artist formerly known as Prince, because the arthritis of CPPD, I think, should formally be known as pseudogout, and I try not to use that term. EULAR, which is the European correlate of the American College of Rheumatology, a couple of years ago tried to fix the nomenclature. I think they actually made it worse, but at least we can talk about what they recommended and what I'm currently doing so that you can understand the rest of my talk. So as I mentioned, these are CPP crystals. We now call them calcium pyrophosphate crystals. They used to be called calcium pyrophosphate dihydrate crystals. Again, this disease has way too many words associated with it. I use the word CPPD, or the abbreviation CPPD, to refer to the crystal deposition in tissues, largely in cartilage, and then CPDD to refer to symptomatic crystal deposition. So the history of this disease, I think, is really interesting. It's a relatively young disease, which may be one of its challenges, initially described in the early 60s by these two Hungarian gentlemen and an American. And it was simultaneously described in a group of patients from Hungary as well as a group of American patients. And the phenotype of those patients was a little bit different. The Hungarian patients, they noticed this radiographic chondrocalcinosis, whereas the American group was defined by the presence of crystals in synovial fluid that were resistant to uricase, so they were not gout, although these patients looked very much like they had gout. And this gentleman, for those of you that don't know, is Daniel McCarty, who was a chair of medicine for many years at the Medical College of Wisconsin. So Wisconsin has a really important role in discovering and defining this disease. What always strikes me as sort of amazing too is that the polarizing microscope, which is really critical to the definition and the diagnosis of crystal arthritis, wasn't invented until 1952. So despite the fact that gout, at least, was described by Hippocrates, we really couldn't definitively diagnose these diseases with a clear diagnostic test until 1952, and I think that's super interesting. And what Dan did was he noticed that some of these patients that looked like they had classic gout, largely in the knee, had uricase resistant crystals, and so had something else. And that is the beginning of the history of CPPD. It certainly illustrates the importance of observational medicine. It's also, I think, a really nice example of bedside to bench pathway that is so critical to medical research. And Dan he is still around, a brilliant clinician who really used his patients to generate ideas that he brought to the lab. I also want to talk a little bit about the fact that CPPD is, I think, an excellent demonstration of sort of progress on a non-life-threatening disease combined with an absence of any interest from pharma. So let me show you what that looks like. So what I've done in this graph, and it's a little bit old, is to look at the number of publications in Ovid versus the affected population. So this is the number of publications of around CPPD, very small, rheumatoid arthritis, and osteoarthritis. And then to look at, using this scale, the number of affected Americans. It's American-centric work, but probably around 10 million affected Americans with CPPD, and I think as the population ages, that will increase. Rheumatoid arthritis, less than 1% of the population, and osteoarthritis, a very, very common disease, but still lagging rheumatoid arthritis in terms of publications. So very, very understudied, but still super interesting. And we've learned a fair amount about the epidemiology of CPPD. As I mentioned, it likely affects at least over 15 million Americans. It's an age-related disease, rare under the age of 60. There's no sex preference that we're aware of. There are familial forms, which I'm going to talk about a lot when we start talking about pathogenesis. And it's also associated with a really interesting group of other diseases. So associated, and I mean higher prevalence related to the presence of hyperparathyroidism, hemochromatosis, hypophosphatasia, and hypomagnesemia. And one of the things that has really interested me over the years is why this sort of odd group of diseases are all associated with CPPD. I also like to call them the 4 H's because that makes it a little easier to remember what they are. The other critical thing about CPPD, we think a lot about cost in healthcare these days, and crystal arthritis is really expensive. And it's expensive in its role in prolonging hospitalizations, particularly for elderly patients. And this is some work from France in 2011, where the annual cost of hospital stays for crystal arthritis was 82 million euros, which I think is around 100 million American dollars. And if you look here, it was pretty much these hospitalizations were equivalently distributed between gout and what they're calling chondrocalcinosis, which is CPPD, but was extremely common after admissions for other illnesses, after surgeries, and we'll talk a little bit more about that. So we're going to segue now into sort of some of the clinical manifestations of CPPD, and one of the difficulties is that these are heterogeneous. So as I mentioned, these crystals can cause an acute inflammatory arthritis, manifest as the gout-like arthritis that we used to call pseudogout, that we now refer to as acute CPP crystal arthritis. And I'm going to talk a little bit about Crown-Dens syndrome, which is acute arthritis of the C1, C2 area in the neck. And then it also causes a couple of different forms of chronic arthritis. It can look like osteoarthritis, but distributed oddly. So joints like shoulders, ankles, wrists, joints that don't typically get garden variety osteoarthritis get CPPD. It can look like osteoarthritis with a clear inflammatory component, so oddly distributed degenerative arthritis, but with acute attacks of inflammation. And it can also look very much like rheumatoid arthritis. So these people have chronic inflammation in joints. And then most rarely is a Charcot-like arthropathy, so a very destructive arthropathy that can look like the kind of arthropathy that one gets with sensory neuropathies. But the best recognized form is acute CPP crystal arthritis, again, previously known as pseudogout. It can look exactly like gout, very inflammatory fluid. Cell counts can be 100,000, 200,000. The two most commonly involved joints are the knee and the wrist. And as I mentioned, other presentations can occur. This patient has some inflammation around their wrist, a little bit of ulnar deviation, so looks a little bit rheumatoid, as well as some clear soft tissue swelling in the MCPs. PIPs. It can also affect the MCPs, and the second and third MCPs are particularly commonly affected, or it can look very much like garden variety osteoarthritis in the hands. Crown-Dens syndrome is a form of acute CPPD that's often unrecognized. It causes an acute febrile illness, severe neck, head pain, very high inflammatory markers, usually sed rate greater than 100. Delirium can occur in some patients, and it's often confused with meningitis. I actually just reviewed a case that was misdiagnosed as Crown-Dens and ended up being meningitis. So a lot of overlap in the clinical features, very important to figure out what you're dealing with. There are some rare clinical observations associated with CPPD. It can occur in the spine and can be very aggressive in terms of destruction, cause a discitis that can be very symptomatic. Unlike gout, which forms tophi and is very common in soft tissues, CPPD is rarely found in soft tissues. And when it does occur there, it forms sort of these tumor-like masses, often adjacent to bones or joints, and can cause a significant tissue destruction. And this is a lovely case report this year of bilateral TMJ arthritis associated with CPPD that was very destructive and incredibly inflammatory. So it can appear in odd places. We've learned also over the last couple of years that CPPD is likely a disorder of systemic mineralization, so that it is associated with bone abnormalities. And this was first described in 2014 by a group in the UK, which had a very well-characterized group of CPPD patients and found low cortical bone mineral density, some increased soft tissue calcification, vascular calcification. And in our study of 27,000 American veterans with CPPD, we confirmed the association with osteoporosis. So pretty interesting, and you're going to hear a sort of consistent theme of is this a bone disease as we progress. So when do you suspect CPPD clinically? I rarely worry about it in patients that are younger than 60. This characteristic joint involvement with wrists, the second and third MCPs, knees, ankles, it tends to spare the first MTP, and that helps you differentiate it from gout. Typically no subcutaneous nodules. They have an inflammatory pattern that lacks symmetry, unlike typical rheumatoid arthritis, and they will have sudden onset of inflammatory attacks. It's very destructive, so it's often associated with very severe radiographic evidence of destruction. Osteoporosis or osteopenia, I think, is a clue to CPPD, and they're very characteristic radiographic findings. So I will show you those in a moment. So chondrocalcinosis and the presence of tendon calcifications are also really important clues to this diagnosis. So we're going to spend the next few minutes talking about diagnosis. So this is a challenge with CPPD because you have to really be able to find crystals in synovial fluid, and these crystals are not easy to find. This is the only set of diagnostic criteria for CPPD, which was originally described by Larry Ryan and Dan McCarty here in Milwaukee in 1985. And the only definite diagnosis required you to identify crystals in relevant tissues using definitive means, which means either FTIR spectroscopy or X-ray diffraction, which very few of us have access to. So what most of us use as a definite diagnosis is morphologic identification of crystals in bipolarizing light microscopy and typical calcifications on radiographs. So the presence of these two criteria, you feel pretty comfortable that you've made the right diagnosis. However, CPP crystals are really hard to see. They're very small, and we've learned over the last 5 or 6 years that many lack birefringence. For those of you that don't think about birefringence on a daily basis, as I do, that birefringence is the property of crystals that make them yellow and blue under polarizing light. So they are the way we identify crystals, and as if any of you have found gout crystals in synovial fluid or looked at them, they're very bright, they're very there's lots of them, they're easy to see, they call your name. However, CPP crystals are not like that. They're sparse, they're small, they're often intracellular, and they are they're really difficult to see. And they come in sort of two forms. There are some needle-shaped, or I would like to call that rod-shaped crystals, as well as these rhomboid crystals that tend to be sort of short and squat. And actually, it's the short and squat ones that are more likely to be birefringent than the rod-shaped ones, which makes it even harder to see. There's some really exciting work, mostly out of UCLA, to improve the way we identify crystals in synovial fluid. And this is a lens-free microscope that it eventually, I think, might be a cell phone app, which is pretty cool, which helps really differentiate MSU crystals, the gout crystals, from the CPPD crystals. And while it was initially fabulous for gout and not so good for CPPD, there's been a recent paper just over the last couple months which shows beautiful pictures of CPP crystals with this modality. So I think this will make things significantly easier. And then we often rely on radiography to help us with this diagnosis. Conventional radiography is the way this disease has been defined over the last 50 years. There's been an increased interest in use of ultrasound. I'm going to talk about that in a minute. CT scan and dual energy CT are exciting modalities for CPPD. And unfortunately, MRI, which is the most common way we image joints, advanced imaging modality to look at painful joints, is not helpful. You cannot see good calcification on MRI. So this is what chondrocalcinosis looks like. It's this nice linear deposition of calcium-containing material. It's often in the fibrocartilage, so the meniscus of the knee and the triangular cartilage of the wrist, and it's generally pretty easy to see when it's there. Tendon calcifications, as I mentioned, are also important clues to CPPD. So this nice linear deposition of calcium here in the quadriceps tendon. Another clue is seeing it along the plantar fascia in the foot. Also very diagnostic of CPPD. And ultrasound has come a long way and may actually be, in experienced hands, more sensitive than plain radiographs for diagnosing chondrocalcinosis. Gout has what's called a double contour sign, where the crystals lie on top of the cartilage, and sometimes that can be difficult to differentiate from the crystal deposition, which is usually in the middle of articular cartilage. So you have to be a little bit careful, but it can be extraordinarily helpful. And lastly, dual energy CT, which I presume many of you are familiar with, which not only identifies crystal, but can actually identify the chemical components of the crystal, are super exciting in gout, where these gorgeous pictures of tophi in joints and in blood vessels and actually in hearts. It took a while for CPPD to sort of catch up with gout, because the mineral of obviously calcium pyrophosphate contains calcium, so differentiating the mineral of CPPD with the mineral that's present in normal bone is challenging. But a recent paper by a French group shows that they can now differentiate meniscal CPPD from subchondral bone and trabecular bone. So we are making significant progress in this area. This is sort of what these images look like. Again, not as pretty as gout, but getting there. And this is ex vivo, so they had to actually remove these menisci from autopsies, I think, before they could do it because of the interference with bone, but excited about that. And then I want to spend the next few minutes, these are usually the questions I get about CPPD when I talk about it. Well, how do we manage these patients? And I think we're actually pretty good at managing acute CPP arthritis, because we manage it almost identically to the way we manage acute gout. I've starred any of the therapies that I'm going to talk about that have even a little bit of evidence behind them. And this is this long list of treatments is never a good sign with a disease. It was like scleroderma was 10 years ago, where we would just throw everything at it. But for acute CPPD, we're pretty good. So there is some evidence that intra-articular corticosteroids are helpful and actually shrink the length of time of acute attacks. We use colchicine. We use NSAIDs, very similar to the way we use them in gout. Systemic corticosteroids are sometimes necessary particularly for polyarticular attacks or in patients that have joint involvement where it's not amenable to injection. We use anakinra and other IL-1 beta inhibitors, and there is some case report and case collection type evidence that those can also shorten the duration of attacks. There's a little trickle of work on IL-6 inhibitors and TNF-alpha inhibitors, and probably a little more evidence for IL-6 inhibition than TNF inhibition. So most patients with acute CPP arthritis we do pretty well on. The real problem and what my patients really suffer from are these patients that have more of chronic arthritis with CPPD, and whether they have acute attacks or not acute attacks, the management of these patients is really difficult. We, in some of them, will use daily doses, low doses of colchicine, and that can be helpful. NSAIDs are difficult drugs to use in this elderly population, but some people benefit from them. Intra-articular corticosteroids, obviously short-acting and not great for long-term management. Many of my patients require systemic corticosteroids. I try to keep doses under 10 milligrams daily, but there are some patients that really, the only drug they respond to is prednisone. I have had some success with IL-1 beta antagonists. We, again, a trickle of literature, mostly case reports on TNF-alpha inhibitors and IL-6 inhibitors, and I would use those with great caution in these patients. There's a little bit of data on methotrexate, and I'm going to show you that in a moment. Hydroxychloroquine is our go-to drug in rheumatology for anything that we don't otherwise have great treatments for, and I've had some success with that. Some people advocate the use of magnesium. If you remember the 4 H's, one of them is hypomagnesemia. I don't like to use magnesium in patients unless they're clearly hypomagnesemic, so I don't use magnesium. We use a lot of medication mixtures in patients with rheumatic disease in general, so we're pretty comfortable with a little bit of that and a little bit of this and mixing it up. So I have a lot of patients that are on colchicine, a little bit of prednisone, sometimes a little bit of methotrexate. And lastly, joint replacement for large joints is identically effective in patients with or without CPPD, and there's actually some literature on that, so that's very reassuring. There are rare attacks of pseudogout or acute CPP or crystal arthritis that can occur after joint replacement, but pretty rare. So let me show you a little bit of the methotrexate data because I think it nicely illustrates challenges with this disease. So this was a trial of a relatively small number of patients. It was done in Europe and was a multi-center trial, double-blind, crossover, randomized control trial. And they basically found no difference between the methotrexate group and the placebo group. The patients were allowed to stay on prednisone as needed, and this was very disappointing to the CPPD community. What was I think the major problem with this study was that they were using scales that we usually use for rheumatoid arthritis to measure disease activity. And the disease activity using those scales was extraordinarily low. I mean, it was near zero in most patients at baseline. So very hard to reduce disease activity when it's zero. And so I'm hoping that with some of these, of the classification criteria work that, again, as I mentioned earlier, is going on at an international level, we'll be able to measure not only patients, identify patients that have very similar clinical phenotypes, but identify scales that are much more applicable to disease activity in CPPD and not use rheumatoid arthritis scales. So I still use methotrexate. I want to spend the next little while talking about pathogenesis. This is really where I have spent most of my energy. I am extremely excited about the work that we're doing in the lab right now, and I'm going to tell you a little bit about that. So when I think about the pathogenesis of CPP crystal arthritis, it has really sort of two, and I want to call them phases, but two parts. So crystal formation occurs in cartilage, and unlike gout crystals, which form in solution, CPP crystals need a solid matrix in which to form. The other interesting thing about CPP crystals is that they rarely form in other tissues. So pretty much tophi will develop anywhere, and as we use some advanced imaging, we know that they develop in blood vessels, and they develop in heart, they develop in soft tissue. You can get them all sorts of weird places, but CPP is really very picky about where it forms, and there's something about cartilage that promotes it. So we're going to talk a little bit about that, and once these crystals form, they can cause inflammation. So what we think is probably they form in cartilage, something occurs to sort of mine them out of cartilage or to produce them, allow them to be released into synovial fluid or synovial space, and then they cause inflammation. And what's interesting is they cause inflammation pretty much identically to the way that MSU crystals cause inflammation. So that is through the inflammasome, and it's likely the NLRP3 inflammasome. So this part, and I hate to say this as a rheumatologist, the inflammation to me is not as interesting as crystal development. So I have spent a lot of my time thinking about why these crystals develop in cartilage and what we might do to prevent that. So I was never particularly interested in genetics until the last 10 years or so. And as I mentioned earlier, CPPD has familial forms, and they really have taught us a lot about pathogenesis. So the work I'm going to talk about in the next couple of minutes is related to these really fascinating familial forms of CPPD, which are monogenic. And I think as a sort of as a principle, obviously sporadic CPPD is not going to be monogenic, but has really identified some pathways that I think are super exciting. So important to remember that CPPD in its initial description in the 60s, the Hungarian cohort had 5 patients that were related. So clearly the familial form has been around for a while. And since then, multiple kindreds with familial CPPD have been described. There are 2 mutation clusters, one on chromosome 5p, which has been called CCAL2, and one on chromosome 8q, which has been CCAL1. And really only in the last 20 years have we learned what these clusters represent. So the first, CCAL2, is a protein called progressive ankylosing protein homolog, another awful name. but familiarly called ANK. And this is the symbol for ANK. So ANK is a really fascinating protein. It's a multipass transmembrane protein, fairly widely distributed, really important in skeletal tissues, bone, as well as cartilage. And there are two kinds of mutations associated with ANK. In humans, there is an ANK mutation in mice that I'm not going to talk about, but there are mutations that cause craniometaphyseal dysplasia, and then there's mutations on the other side of the protein which cause familial CPPD. And this was described in the 2000s by a group in shortly after ANK was discovered, which was in 2000. In 2002, work with a library of patients with familial CPPD showed that ANK is syntenic with the 5P location of familial forms of CPPD. And so they found multiple kindreds with classic familial CPPD who had gain of function mutations in the ANK protein. So what does ANK do? We'll talk about that in a minute, but a lot of my early work concentrated on pyrophosphate. Pyrophosphate is the anionic component of the CPP crystal. It's very highly produced by chondrocytes. This represents a chondrocyte. And pyrophosphate is classically known as an inhibitor of basic calcium phosphate or hydroxyapatite crystal formation. So cartilage has a vested interest in keeping its matrix unmineralized. And so basically constitutively produces a fair amount of pyrophosphate. And that's one of the reasons why calcium pyrophosphate crystals may be so unique to articular cartilage is that pyrophosphate is there. It's present in many tissues. And we've learned over the last 10 years or so that most extracellular pyrophosphate, which is available to make CPP crystals, is formed from extracellular ATP. So there are a set of enzymes on the outside of chondrocytes that take extracellular ATP and make it into pyrophosphate. And we've known for a while that many cells produce extracellular ATP. That seems a little counterintuitive, as ATP is really important for energy metabolism. Why would you want to leak it out into your extracellular space? And it's important probably in cartilage as a mechanotransducer. So this is work from my lab, which shows that chondrocytes generate extracellular ATP in an osmosensitive manner, which probably translates to mechanosensitivity. So as you decrease the amount of, whoops, let's go back to that. As you decrease the amount of solute in the solution, chondrocytes respond by making more ATP. A lot of this work is done with porcine chondrocytes. We always worry about chondrocytes and their relationship to matrix. So this work was done in monolayer chondrocytes, which are very densely cultured, as well as in agarose embedded chondrocytes, perhaps more similar to their native environment. And then we showed subsequently that ANK critically regulates ATP and pyrophosphate levels around chondrocytes. So when we overexpress it, it makes more, the chondrocytes make more ATP and pyrophosphate. And this figure shows that when we silence it, which we did fairly effectively, there's a decrease in both extracellular ATP levels as well as a significant decrease in pyrophosphate levels. So that's really nice. Here is a protein that is potentially druggable and seems to be very critical for the production of pyrophosphate by chondrocytes. However, most of the last 30 years of research on CPPD pathogenesis really focused on pyrophosphate and cartilage, but this didn't really explain everything. And one of the things that was most interesting to me was that some of the metabolic diseases associated with CPPD had no effect on cartilage and no effect on pyrophosphate. For example, high iron levels, such as those that you would see with hemochromatosis, had no effect on cartilage or pyrophosphate production. And parathyroid hormone also did not appear to affect pyrophosphate production or really have a particularly significant role in cartilage disease really at all. The other interesting the thing that was missing were those 8Q families. So the families that did not have ANK mutations, what was going on with them? And then in 2015, we noticed this paper, which was from a group from the Netherlands, which described a family that had a gain of function, they thought, mutation in this gene called TNF-RSF11B, which encodes for a protein called osteoprotegrin. And these patients had severe early osteoarthritis with very exuberant chondrocalcinosis. And I have worked for many years with Charlene Williams, who has a library of these kindreds that have familial CPPD. And she went back and looked at some of her families, and we found another family in Long Island just because someone emailed us and said, I have this interesting family, and they wondered about an ANK mutation. And so we found 3 additional kindreds that had this identical mutation in osteoprotegrin. And let me introduce to you osteoprotegrin to those of you that don't think about osteoprotegrin on a daily basis. So it's critical for normal bone remodeling. So osteoprotegrin is a bone protein. It's a very interesting protein. It's a decoy receptor for a rank ligand. And if those of you that remember bone remodeling pathways, rank ligand occurs on osteoblasts and binds to pre-osteoclasts, binds to a receptor called rank on pre-osteoclasts and promotes osteoclastogenesis. So osteoprotegrin, functional osteoprotegrin prevents osteoclast formation, and dysfunctional or short supply of osteoprotegrin will promote osteoclastogenesis. This is what the protein looks like, and the mutation described with CPPD occurs in the stop codon in the C-terminal and results in an additional 19 amino acid tail on this protein. So we became very interested in both bone, and my lab has worked with cartilage for 20 years, and I always used to say I don't really like bone. It's got too many different kinds of cell types in it, and I have an aversion to Haversian canals, but I've really begun to embrace bone, and I'm super interested in osteoclasts. And so initially, we showed that the mutation, it was initially described as a gain of function based on very weak data. And we have recombinant protein now, very well characterized, and it's clearly a loss of function. So this, when this mutation occurs, there is an increase in osteoclastogenesis. So interestingly, these patients have some mild osteoporosis as well as this very destructive premature osteoarthritis and chondrocalcinosis. This is an osteoclast. These are examples of what we did with a co-culture system as well as a monoculture system of osteoclastogenesis. This is the wild type protein. This is the mutated protein, and in all of these conditions there is significantly less blockage of osteoclast formation as measured by Q-trap levels with the mutated protein compared to the wild type protein. So this didn't really explain all of the phenotype that we see in these patients, but we have a lot of really interesting hypotheses and a couple of grant applications, which I have my fingers crossed we can fund and get moving with this. We also just have had some remarkable early success with a CRISPRed mouse containing this protein. So I'm super excited about this. And what we think is in these patients, there is abnormality of OPG, which results in increased osteoclastogenesis. We have some really interesting data that something elaborated by an osteoclast probably crosses the subchondral plate and increases pyrophosphate production by cartilage. And then pyrophosphate, which is an extremely bioactive compound for bone, probably leaks back into this subchondral space and works on, we think, on osteoblast rank ligand to sort of feed back and make this nice cycle of too many osteoclasts, too much pyrophosphate, too much rank ligand on osteoblasts, and a cycle which not only causes a mild bone phenotype, but causes an arthritis phenotype because it focuses the damage on the joint because of this interaction between cartilage pyrophosphate and subchondral bone osteoclasts. So we've got some exciting data on that, hopefully coming out soon. But it also, I think this genetic work has really shown us that these two proteins produce slightly different CPPD phenotypes and clearly support two potential different pathogenic pathways for CPPD. So probably CPPD, like many types of arthritis, is sort of a final common pathway for two different things. Some focused on cartilage and pyrophosphate, like ANK mutations, hypophosphatasia, which is a deficiency of alkaline phosphatase, which is a major degradative enzyme for pyrophosphate, and potentially hypomagnesemia, which is also an important cofactor for many of the enzymes that metabolize ATP and pyrophosphate. And then another group where it's a primary bone abnormality and the focus is on disordered bone remodeling. And this would include OPG mutations, hyperparathyroidism, in which there's really abnormal bone remodeling, hemochromatosis, in which patients have a osteoporosis, as well as iron has a very vigorous role in affecting osteoclast formation, and probably a lot of sporadic CPPD and age-related CPPD, where we know that some of the osteoporosis that occurs with age results from increased osteoclastogenesis and may be an important pathway in developing CPPD with age. So to summarize, I think that improved understanding of the pathophysiology should lead to new potential therapies. And I think in this disease too, probably when it's well established, it may be too late. And that is another reason why I feel so passionate about focusing on crystal formation rather than inflammation. I think if we can stop these crystals from forming relatively early on, we may be able to stem some of the major joint destruction before it's too late. So ANK is a druggable target. It actually there's some very interesting data recently that ANK may also transport organic anions, and so there are a variety of drugs, including drugs like probenecid, which target organic anion transporters. And so this is an example of work from our lab, again, where probenecid, which is an organic anion transporter, significantly reduced ATP and PPI production by chondrocytes. And then we all know that denosumab, for example, is an anti-rank L drug, so mimics the effect of functional osteoprotegrin. And again, this pathway may be a really important one for CPPD in the future. So I want to end here by just reiterating some, I hope, important points. CPPD is really common and will become increasingly common as the population ages. It's an expensive disease that often extends hospital stays, has important Wisconsin roots, so we should all know about it. I'm hoping that better disease definitions and diagnostic modalities, which are on the horizon, will really improve our ability to treat this disease and to study it in clinical trials. I think we're learning more about the pathogenesis and the fact that subchondral bone is really critical to the development of this type of arthritis. And we're excitingly beginning to identify some druggable targets for CPPD. So I want to thank everyone for listening, and I'm happy to take any questions.
Great. Thank you so much for a wonderful overview. I learned a lot. It's not a disease that I think about as a critical care doc that much, so it was great to learn about.
It's a good break from COVID, right?
Yes. Almost anything is.
I didn't mention COVID once.
It's pretty impressive. There's a couple of questions about the clinical presentation. So one from John Arneson, thank you for an excellent talk. That occasionally he sees some younger patients, 30 to 50, with CPPD. Is their workup or presentation any different from the typical older patient?
That's a great question, and yes, there is, because we work them up for these secondary causes of CPPD if this disease occurs in patients under the age of 60. So I'll do iron levels, I'll do transferrin levels, I will look for alkaline phosphatase abnormalities, and I will look for evidence of low magnesium. So there is a whole recommendation of a metabolic workup that we do in young patients. Also important to ask them about family history. You know, at this point, I sometimes will get inquiries about, you know, whether people should have genetic testing for either ANC mutations or OPG mutations. I'm not sure we're there yet in terms of either genetic counseling, really, or different kinds of treatments based on that, but it's something to think about in the future.
Yeah, I was going to ask that, and actually Kelsey Hilbert had exactly that same question. What population do you think about genetic testing? It sounds like a good family history is first.
A good family history and premature onset. These patients typically are, particularly the OPG patients, are 20 and 30 when they develop this really dramatic arthritis. So not hard to see in most patients.
Great. Another question from Michael Madelon. Recognizing an acute attack, that is when to start a drug, a nonsteroidal, is hard enough. How do you determine how long to treat a patient for? What's the duration of therapy?
That is a great question. The acute attacks of CPPD tend to last longer than gout. We think of gout attacks untreated as 5 to 7 days. And CPPD can last like 7 days to a month, frankly. They can last for a long time. So you have to tailor that to the patient a little bit. If you can catch the attack early enough and treat it aggressively, you usually can wipe it out in a couple of days, but in general, you have to tailor that to each patient. Some patients will feel great in 3 days, other will still have significant inflammation, and you're going to have to extend your treatment. And we use a lot of steroids in these patients. We understand the downside of steroids, but they often don't tolerate other modalities.
So I'm hearing duration of therapy is longer than you might think.
Longer than you might think, and you have to really look at the patient.
Yeah. I have a question. I was intrigued by the story about the generation of extracellular ATP and its role in development in the crystal formation. I think of extracellular ATP as being a DAMP, as being a pro-inflammatory signal itself. So is there another role for extracellular ATP in inflammation that is early and independent of the development of crystals, or may be at the same time of crystal formation?
That's a great question, and we've thought a lot about that. We've actually have a study to look at ATP levels in patients with sort of chronic CPPD that don't have data from that yet, but you're absolutely right. The other interesting question is pyrophosphate, which is a major metabolite of ATP in bone and cartilage. It may also be a DAMP, and we don't really know, but may act through some of the same pathways as ATP. So super good question. Don't have an answer. Cartilage is, kind of an inflammation protected niche, and these crystals form in the mid zone of cartilage. So they don't have typically a lot of exposure to regular inflammatory cells, and there's very little evidence that there's true inflammation in the cartilage itself. The inflammation occurs when these crystals are elaborated into the synovial space. So it may be the same with ATP. I don't know.
Okay. And then one last question from Phil Cohen. Is there an association with trauma, I would assume with repeated trauma to joints, et cetera?
There is an association with trauma. It's fairly loose, and we don't really understand it perhaps as well as we should. But for example, after meniscal repair, there is a fairly high risk of the development of these crystals in the meniscus. So we don't exactly know whether that may be a local phenomenon related to injury, but injury is probably critical to all forms of arthritis, frankly.
Okay, great. Well, we are 1 minute over the hour, so we will stop here. I want to thank Dr. Rosenthal for a wonderful overview, and we look forward to continued collaborations and enhancing the Wisconsin connection in rheumatologic diseases and our footprint in this area. And I will get to Milwaukee at some point soon. So
great.
Thank you, everyone.
Thank you so much.
Take care. Have a great weekend.
All right. You too. Bye-bye.